Good morning, everyone. I'm Dr. Vijay Shetty. I'm speaking on behalf of Dr. NITIN DESHPANDE as he is not able to come. So the paper is astigmatic changes of intrastromal relaxing incision performed during femtosecond cataract surgery. Femtolaser assisted cataract surgery involves use of femtosecond assisted construction of corneal incision, capsular excess, and lens fragmentation. Rest of the steps are completed using standard phacoemulsification procedure. In addition, femtosecond laser is capable of performing intrastromal relaxing incision for correction of smaller astigmatism. Commercially available femtosecond laser platforms include Lensex, Catalyst, Lensar, Victus, and FemtoLDV. All these systems use the same solid-state femtosecond laser with a pulse duration in the femtosecond range. The imaging system in Lensar platform is Scheimpflug imaging technology, whereas in other machines use spectral luminosity. These are the unique features of the Lensar system on which we have made a study. Femtosecond laser allows a precise placement of arcade keratotomy incision in patients undergoing FLACS. So the factors affecting outcome of FSAK include type of preoperative astigmatism, eccentricity of the cornea on topography, biomechanical properties of the cornea, and arcuate incision characteristics. So aim of our study was to study the visual and refractive outcomes in patients who have undergone femtosecond laser assisted arcade keratotomy with FLACS. And secondly, to study the refractive efficacy of FSAK and factors affecting refractive efficacy of FSAK. The patients between ages of 40 to 90 years with an preoperative astigmatism of 0.5 to 1.5 diopters were included in the study. Patients with corneal pathology and previous ocular surgery were excluded from the study. Astigmatic measurements by keratometry was made by Sirius topography and IOL-Master 700. Nickman-Woodcock nomogram was used for arcuate incisions. These are the preoperative data that were collected. We also calculated the efficacy of arcuate keratotomy using the formula 1 minus postoperative cylinder divided by preoperative cylinder into 100. So standard statistical methods were used for analysis. Nearly 50% of the patients were between 60 to 69 years, and equal distribution was seen in male and female population as well as the laterality of the eye. The median corrected distance visual acuity was 6.6. Both uncorrected as well as distance corrected visual acuity was similar. So this shows that like the FSAK worked really well. Median preoperative cylinder was 0.61 diopter and median postoperative cylinder was 0. So again with a significant p-value. 70% of the patients had a residual cylinder less than 0.25 diopters. 90% of the patients had residual cylinder less than 0.5 diopters. Only 10% of the patients had residual cylinder greater than 0.5 diopters. Patients with residual postoperative cylinder greater than 0.5 diopter had a preoperative astigmatism, had a larger preoperative astigmatism, and a larger arc length was used. So higher percentage of patients with refractive efficacy less than 100% were seen in patients with preoperative against the rule astigmatism. So in a subset of patients with refractive efficacy lesser than 100%, mean eccentricity value was lower compared to subgroup with refractive efficacy of 100%, suggesting lower eccentricity value was associated with suboptimal outcome of FSAK. So to the best of our knowledge, this is one of the first studies using Nickman-Woodcock nomogram on Lensar platform. The results show that FSAK significantly reduced preoperative astigmatism with high proportion of eyes had a postoperative cylinder of 0 to 0.25 diopters. Postoperative uncorrected visual acuity was similar to best corrected visual acuity.
Please.
To conclude, FSAK is a reliable method to reduce preoperative corneal astigmatism. The factors associated with less than 100% postoperative efficacy include higher preoperative cylinder, lower eccentricity value of cornea, and against the rule astigmatism. Thank you.
You are losing marks if you don't stop on time. We are supposed to mark you less if you don't stop on time.
Okay. Yeah, Vijay, so what is your inclusion criteria? I don't think that was clear. How much astigmatism is there?
0.5 to 1.5 diopters.
1.5. You're stopping at 1.5.
Yes.
And beyond that, you're going for a toric IOL.
Toric IOL.
90% of your patients had up to 0.5 residual.
Pardon?
90% of your patients had up to 0.5 of residual cylinder. Is it not?
Yeah, less than 0.5 diopters.
And how long do you have follow-up on this?
We have follow-up up to 6 months.
6 months. 6 months is not so very enough for these cruciate incisions to
Yeah, there may be
relax and then
regression
regress
later
back.
on.
And you have selected from 0.5 to 1.5,
Right.
and 90% are still have 0.5.
Yeah, because some of the this is a median actually.
Thank you.
So it's a fair study. Like we do a lot of LRIs on femto, and the results are not predictable. We've tried various combinations, and they do not even last very long. Hence, the predictability in nomograms are difficult. So even if your conclusion is that it doesn't work in more cases or doesn't stay long, that's fair. I mean, a study is to establish that part, but probably just a longer duration. Maybe you can do a more follow-up, will make it more concrete. What was the result at the end of the 1 year? Because the effect of arcuate do wear off
Yes.
over a period of time. So, but good effort.
Thank you.